I'm going to do a commercial talk here, but I'm going to bring you back to the future, and that's on PRP, which I call the original advanced wound healing agent. Many of you might remember the early days in the 80s when PRP became very prevalent, and there was a lot of excitement about this. And with the subsequent decades, it's used very frequently, but many of us have not been using it extensively for wounds with all the other new types of products. But I want to bring you back to the future again so that you can refamiliarize yourself with, I think, this very, very important modality that can expedite wound repair and regeneration with just one or two applications to get a good amount of healing, let's say significantly more healing in 12 weeks compared to controls. I don't really need to go through the demographics and statistics here, but we do know that the diabetic population in America is about 38 million. If you look at the global population of diabetic patients, it's about 537 million. And the statistics always far supersede the actual predictions 4 years before. If you look at the International Diabetes Federation, they produce an atlas every 4 years, and they make a prediction for the next 4 years how many diabetic patients there will be. And the actual numbers are always far exceeding the predicted numbers. So we know that with the increase in number of diabetic patients, there's going to be an increase in the number of lower extremity complications and wounds. And I think most of us are well aware of the chronic wound healing stages here. And I think it's most important to recognize the various components, the cellular and cytokine components within each of the stages of inflammation, granulation angiogenesis, reepithelialization, and tissue remodeling. And of course, cellular components and cytokine and growth factor components are all key elements of each of these processes. So really, it's a sequence of events. It's not just one blast. It's a sequence of events over time at the right time to effect a final healing. But I think we're all well aware of this, and I don't need to go beyond it. So over the last 3 decades at least, there's been an explosion in the different types of advanced wound healing products, many of which John Lantis had already discussed earlier. But one of the main new advanced agents was really Regenerative in the mid-1990s, and that really hit the market with a bang, if you will. But it was overutilized, it was overpriced, and it was undermarketed to the proper patients because they were delivering it just as a gel without paying attention to proper debridement, assessment, and offloading. And so it really didn't have the effect that it should have had. But subsequently, we have a number of extracellular matrix scaffolds, many of which you all have used and were referenced previously. Then you have your cell-based technologies, the biosynthetic, bioengineered products, of course, and we also consider all the amnion products, negative pressure wound therapy. Some have come and gone, and there's other new devices on the market now and coming forward. So we have to realize that platelet-rich plasma has undergone several clinical trials. It's one of the earlier types of advanced wound healing agents, and we'll get into that shortly. But also hyperbaric oxygen, we mentioned that yesterday, topical oxygen as well. Unfortunately, as I said yesterday, hyperbaric oxygen studies have really not been corroborating the positive wound healing effects at, let's say, 12 weeks. And they've been very inconsistent in their outcomes, probably because of the complicated nature of the process as well as the patients. Whereas topical oxygen, really there's been a resurgence in interest in this because of the recent data. Then we also have what I call ultrasonic spray mist therapy, which had one trial. I think there was another one that came out as well, which just can help prepare your wound bed. There was superoxidized water, Manuka honey, medical larvae, electrical stimulation, which physical therapists use far more, I think, than podiatrists in most wound centers. And there was even a pulsed radio frequency energy device that was promoted a decade ago or so for wound repair, although its primary indication was for pain. So, and as John Lantis had alluded to, it can get very confusing. When do you use what and why are you using it? Do you want autologous? Do you want synthetic? Do you want a matrix? Do you want a cellular? Do you want an active growth factor delivering agent, or what have you? So it can get kind of complicated. So I want to get back to the original advanced wound healing agent, and I remember these days it was David Knighton out of Minnesota who produced the first work on autologous platelet-derived wound healing factor, as he called it. And this led to the development of those curative wound centers. Maybe some of you will remember the original wound centers in America were called curative wound centers, and their whole premise was based on the platelet-derived wound healing factor, which we now know as PRP. And what he did in his first publication was just his initial work on 49 patients. The majority of them were diabetic and a variety of types of wounds, who had chronic wounds that were non-healing for a long period of time. And once he applied his autologous platelet-derived wound healing factor, they noted a rapid increase in healing of these chronically stalled wounds. And so it was a mean 100% healing time for all patients, 10.6 weeks. So that really started the current era of advanced wound care products. And again, it was PRP, the original wound healing agent, and that's what I'm here to talk about today. So now we know it's platelet-rich growth factors, platelet-rich plasma, platelet-rich fibrin matrix. And the problem is that we have our chronic wounds that are stalled due to inflammation, chronic high levels of MMPs, proteases, etc. And what the growth factors and the cytokines that such a product can deliver will convert that pro-inflammatory process to a more tissue regenerative process, or I call it a synthetic type of a process where your cells are actually synthesizing growth factors. Your macrophages are synthesizing growth factors rather than acting as in the pro-inflammatory state. So why platelets? Well, they're very easily available, of course. They have many alpha granules, which release hundreds of proteins and growth factors. Extracellular vesicles are released when platelets are activated. And in the wound, they signal the recruitment. It's more of a paracrine response and signal the recruitment of other cells and releasing growth factors themselves, of course. Platelet-derived growth factor was one of the original ones studied commercially, of course. And the cytokines released also have immune functions as well, which really can help to modulate the inflammatory milieu that you see in chronic wounds. And I think one of the most important things is recognizing the macrophage dysfunction in chronic wounds. And we know that macrophages have two phases. The M1 phase is that pro-inflammatory phase where the primary role is phagocytosis and destruction of bacterial pathogens, of course, releasing a lot of enzymes which are pro-inflammatory and detrimental to wound repair. And then, of course, the natural process is that the M1 phase is transitioned into an M2 phase, and which is more of a synthetic anti-inflammatory phase, which is where we get our tissue regeneration and release of numerous types of growth factors. Neutrophils are an important part of the wound healing cascade, but they can also be inflammatory, of course. And so if there's too many neutrophils in a wound that are releasing their traps and their proteolytic enzymes are going to be counterproductive for healing your wound. So you have to keep that in mind, that excessive amounts of neutrophils in a wound are pro-inflammatory. They're not pro-tissue regeneration. And so here we see in the diabetic host, there's an excessive amount of monocytes, but the macrophages are dysfunctional here, and they're not phagocytizing like they should be. And then also, as we recognized, macrophages in the diabetic host, in the chronic wound, are in that M1 phase and have not yet been converted to the M2, the secretory phase. So by adding large number of monocytes and lymphocytes with the platelets in PRP, we can transition the M1 macrophages to the pro-angiogenic M2 macrophage. And that's really the importance here. Macrophages are key components in wound repair, both for their phagocytic activity, their pro-inflammatory activity, but the essential anti-inflammatory synthetic activity. They're really a synthetic powerhouse when it comes to growth factors and cytokine releases. So the addition of monocytes, as I said, shifts the balance away from the pro-inflammatory macrophages to the synthetic M2 macrophages. And this enhances angiogenesis as well as the release of the appropriate growth factors in the appropriate temporal sequence. And it's really very important. Obviously, as we can see, the macrophages regulate fibroblasts and the myofibroblasts as well as the keratinocytes through their proper sequential release of appropriate growth factors. So I'm introducing this system called the CASCADE Autologous Platelet System, which is an FDA-approved system. It's a point-of-care system that's all self-contained, and you just draw the blood, spin it down. And what's unique about this process, which I really like, is that it produces a membrane. It's not what I call wound slop, where you just have a viscous mess of a gel that can slide off of your wound. This is a membrane, a fibrin membrane, which also trapped monocytes as well. And you can place this into the wound. You can suture it if you like, or just put it on compression. And this is what makes it unique. This is what attracted me to this device, because of the unique application. And again, it's the secret is in the sauce, if you will. The secret is in the gel and the separating gel to separate the different types of components in the blood plasma, from the blood and the plasma, trapping monocytes and platelets alone, and excluding other cells, including your neutrophils, so that you can get a nice fibrin matrix here. So that's what really makes it a difference. You have the autologous platelet-rich plasma with all of the inherent growth factors of platelets, but it's leukocyte poor rich plasma. Leukocyte meaning a neutrophil poor, because neutrophils, as I said, are pro-inflammatory. The uniqueness is also in this platelet-rich fibrin membrane, which is very, very unique. It's not just a wound gel that can slide off of your wound. And it's got over 100 growth factors that are released in a temporal sequence. It's not just a single blast where you're releasing a lot of growth factors at one time with thrombin, let's say. So these are just some other images of the tubes that you'll get after you do your centrifugation and your release. So this delivers a mononuclear platelet-rich fibrin matrix for wounds containing the platelets and peripheral blood mononuclear cells, which are really important immunological cells. Not so much in this country, but in Europe, many of our Italian friends are using monocyte therapy to treat their wounds. And they've done a number of studies on neuroischemic wounds, no-option patients where they're delivering monocytes and affecting wound closure in these no-option wound patients. So monocytes are really a key component in the wound healing cascade. Why? Because they they help in that transition from the M1 to the M2. And there's probably a lot of other factors involved as well. Now, the other thing that's important for this system is that there's no thrombin activation. Most all the platelets in other systems are activated by adding thrombin to it. Any of you who have done this for wound repair or have done prior trials with PRP know you have to add thrombin to it. But we'll get to a slide in a minute or so. The thrombin is not really a good way to activate the platelets. So I'm not going to go through this. The platelet recovery, though, that you get with the CASCADE system is about 90%, which is really, really quite good. Now, this is a picture of the two different types of PRP activation. This system activates platelets naturally, but without thrombin. Okay, so these are the intact platelets after they're delivered to the wound, or after the completion of the process. Here is representing when you're activating platelets with thrombin. You have an explosion of numerous growth factors at one time, and many of us remember the days with Regranix, Bacaplermin gel, where you're just applying one growth factor at one time and not following that normal sequence of release. So by not using thrombin and by having intact platelets in the PRP platelet fibrin matrix, the platelets can release the release the growth factors naturally without the use of thrombin. And I think that's really a distinguishing factor here as well. So you have sustained release of growth factors. We mentioned neutrophils before. This is called the neutrophil extracellular traps, which are pro-inflammatory. And remember, excessive numbers of neutrophils are anti-angiogenic. They're anti-regenerative properties. So we don't want a lot of neutrophils in the wound. This system eliminates the neutrophils. Remember, it's a leukocyte-poor PRP system. So we don't want to have these because they can be pro-inflammatory. And that's what makes this system different from others as well. And here we can see the sustained release of a variety of different growth factors over the course of hours after draw. Rather than have an immediate increase after thrombin activation with slow decrease, we're seeing a slow but steady increase and release over the course of hours, which is really what you want. And so these are some clinical cases. A clinical trial is planned right now, as you would expect. But I think, and I think I mentioned this yesterday, wouldn't it be nice to be able to do one application, two applications of an advanced agent and follow your patients for healing over the course of 12 weeks and see if we can affect final closure, rather than having to apply a very expensive agent week after week after week, 8 to 12 times. So that's also what's attractive for this, as you'll see, the average number of applications of this product for these chronic wounds was about 2 to 3 applications to affect final closure. So this was a simple VA Palo Alto study that was old. They just did five patients. It was an exploratory hypothesis generating the trial. And they found that 80% of the patients healed completely by 12 weeks after just 2 to 3 treatments. As you can see, it was 2.8 treatments. So these are chronic wounds that have failed standard of care, failed other types of treatments, but with 2 to 3 applications of this, they can affect final healing. And I think that's attractive as well. Now, obviously, this is just anecdotal. They were fairly good-sized wounds, but of course it's anecdotal data, and that's why, of course, we also need an RCT, even if it's an open-label RCT. These are just some representative cases, as you can see. Here is the disc, as I call it, the membrane. It's a flexible membrane. It's not like a wafer, like a host. It's a flexible membrane that can fit into the wound. You can suture it if you want. You can roll it up, put it underneath tunnels and that. So it's very, very interesting. And this is what it would look like. And in this patient, the patient healed in 6 weeks with 3 applications. So this was the top end. To me, I would love to get there with 1 application, 1 to 2 applications tops, so that we don't have to keep spinning down the blood. But these are autologous growth factors released over a temporal sequence of time, which is different than most other products. Here's another one with a VLU, 85-year-old, 12-month history of venous leg ulcer, healed in 4 weeks after the 3rd treatment. Very good for chronic wounds. So it just substantiates the value of autologous platelet-released fibrin matrix. And this is another one. This one came right from Englewood Hospital here. This wound had been very chronic for years, many, many years, and healed in about 4 months with cascade membranes. Again, these are anecdotal cases, but these are also hypothesis-generating cases. You should be looking at that saying, that's pretty interesting, because a lot of my patients don't want these off-the-shelf or bovine or porcine products for whatever reason, but autologous factors are very, very satisfactory for some people. And with the activity that we can see in these products, they can really help to expedite the repair of very chronic wounds. And we could go through cases all day long, but you get the point, and we certainly do need to see the results of our trial. So we're introducing platelets into the chronic wound, releasing growth factors and cytokines in a temporal sequence. And I think the temporal sequence is really critical. This particular fibrous matrix membrane also is loaded with monocytes. And the monocytes help convert the chronic macrophages in that M1 stage over to M2, and that's a good mechanism of action as to why this really works. We recognize that macrophage activation or macrophage transition from M1 to M2 is critical, because the M2 macrophages, as I've said several times, are the great synthesizing powerhouses to release the variety of growth factors at the appropriate time in the wounds. There's a new generation coming out that's going to be even more monocyte rich than the current generation, but we're going to be doing the trial on the current system, which you see on your left here. It's just that the new system is going to trap more monocytes, because we really think that monocytes play a much more important role in wound repair than we've ever really appreciated in this country before. But it piqued my interest because I know my friends in Italy are doing a lot of work, and they have been doing a lot of work with monocytes, even as sole treatments for chronic wounds and chronic neuroischemic wounds. So there's something to be said about this monocyte component. So with that, I want to thank you. I just wanted to introduce this new system to you and to get you thinking back to the future about the original advanced wound healing agent and how we can use a patient's autologous blood to expedite healing of these chronic wounds. So thank you very much for your attention.